of Clinical Anesthesiology at University of Illinois College of Medicine and attending anesthesiologist at Chicago. He is also associated with American Board of Anesthesiology and Internal Medicine certified. He is anesthesiologist of international fame and deliver various lectures at the conference. With this much of few words, I would like to request Dr. Hertz to start his deliberation.
Thank you very much. Today's talk is going to be extremely practical. It's going to be about Desflurane. For those of you who heard my talk yesterday, I tried hopefully to bring the point and make the point of why to switch from an agent like isoflurane to more soluble agents. What I'm going to do today is to hopefully give you an argument as to why I use Desflurane almost exclusively in all my anesthetics. I've been here in India for the past week, being sponsored by Baxter, speaking about Desflurane and demonstrating to a lot of the anesthesiologists the technique that I use. Over the past week, I've been in 10 different hospitals, 12 different hospitals. Everyone was gracious enough to let me into their operating rooms. What I did was not only give them a talk about what I did, I demonstrated my technique. Over the course of 1 week and doing 10 anesthetics, my goal, basically in every patient, was from the end of the surgery, from the end of the dressing going on, my goal was to get the LMA out or the endotracheal tube out within 1 minute. I was successful in every single case. Whole variety of cases, neurosurgery, ASA4 cases, and just standard routine cases, LMAs, endotracheal tubes. So we're going to go into the technique very shortly also. Question, why even use Desflurane? I hear this question very frequently. The variant of this question is, what's the difference between Des and Sevo? Aren't they the same agent? And I think what people, when they ask that question, what they're doing is they're looking over here. And they're looking at the blood gas partition coefficient. And if you can see, Des and Sevo are virtually the same. 0.45, 0.65, what's the big difference? The thing to keep in mind is these are relative blood gas solubilities. It's not the absolute difference, it's the relative difference. Okay, I like to look at it like this. Des 0.45, Sevo 0.65, isoflurane 1.4. Sevoflurane is almost 50%. Sevoflurane is almost 50% more soluble than Desflurane. Same chart, what I've done is I've normalized the numbers here to make it a little bit easier to understand. If Des is 1, Sevo is 1.44 times more soluble than Desflurane, almost 50% more soluble. And isoflurane is three times more soluble than Desflurane. In this scheme, if you're looking at these three agents, isoflurane is the soluble agent, Desflurane is the low soluble agent, and I think of sevoflurane as the agent of intermediate solubility. So you're going to ask yourself, you're going to ask me, that's fine, these are all numbers. Does this mean anything in real life? How does this translate? So let me share a couple of studies with you. I like this study for a number of reasons. First of all, it compares Des, Sevo, and isoflurane. These are sicker patients. They're having pulmonary surgery, so either lobectomies or pneumonectomies. Okay, healthy people don't have their lungs removed. And I think the authors here fell into the same trap that most of other people fell into. What they were looking at was to see a difference between Des and Sevo versus ISO, expecting the wake-up times between Des and Sevo to be quicker than isoflurane. So let's see what they found, because I think they were surprised by the results also. They looked at 100 patients, pulmonary surgery, so we're talking pneumonectomies or lobectomies, randomized prospective 37 Desflurane, 29 sevoflurane, and 34 isoflurane. All the cases were longer than 2 hours, 2.5 to 3 hours. Volatile was titrated to keep the heart rate, blood pressure within 20% of the baseline. If they were unable to do that, they added narcotic. The narcotic they were typically using was sufentanil. Let's look at the results. Time to eye opening, Desflurane 7.2 minutes, sevoflurane 13.7 minutes, isoflurane 14.3 minutes. I don't think they were surprised at the difference between Des and isoflurane. I think what they were surprised at was Sevo pretty much looked like isoflurane. The difference in eye opening between Desflurane and sevoflurane marked and highly significant. Let's look at time to extubation. Same thing, 8.9 minutes. Sevo almost twice as long, 18 minutes, and 16.2 minutes for the isoflurane. Again, marked differences between the Desflurane and the sevoflurane, highly significant. Keep in mind, even though those blood gas solubility numbers look identical, Desflurane and sevoflurane are not the same agent. Let's look at one more study quickly. You're going to tell me, you know, I practice in India here, not in the United States. In the United States, everyone is large, and that's true. We have a lot of people with large BMIs. Surely you're not going to tell me that if we do very, very short cases in people of normal body habitus with low concentration, surely we're not going to see any difference in wake-up times. So let me show you this study over here. This is a study done by Mahmood, and what she looked at was Des versus Sevo in short outpatient gynae procedures. 60 outpatients, minor gynecological surgery. So what's minor gynecological surgery? Primarily two procedures, D&Cs and hysteroscopies. Short cases. How short? Average length of time was 19 minutes. The cases ranged from 9 minutes to 30 minutes. So typical what you would expect. Clearly short cases. Standard IV induction, spontaneously breathing via LMA, randomized to either Desflurane or sevoflurane, less than 1 MAC. Let's look at the results. Time to eye opening. Desflurane, 2.8 minutes. Sevoflurane, 7 minutes. Big differences, highly significant. Time to orientation, 4.8 minutes versus 9.8. Big difference, highly significant. Ready to leave the recovery room, 15.5 minutes versus almost 24 minutes. Again, difference significant. Now, here's the most interesting thing of this study. They gave follow-up calls the next day and got a hold of literally every patient. And the question they asked was, how many of you are back to full activity? From the Desflurane group, 28 of 31 and only 15 of the 29 Sevo patients. Remember, these were short patients, non-obese, low concentrations of volatile anesthetic, significantly different wake-up times and time to the PACU admission and back to full activity the next day. Keep in mind, this is one of the reasons why I use Desflurane not only for my obese patients. I use Desflurane pretty much for every single volatile anesthetic I do in an adult. Let me go over my technique. Is this the only technique out there? Absolutely not. Is it the best technique out there? Absolutely not. And the reason why I know is because the technique I use today is not the same technique I used 2 or 3 years ago. As I go around and speak to audience and I get feedback, I change and try and make it better. The drugs that I used and the drugs that I used over the past week, even though we do have some different drugs you don't have available, they're all standard drugs that I have in the US, and this is how I would have done my anesthetic too. Let's look at a typical case. Lap chole, 48-year-old woman, 168 centimeters, 114 kilos, obviously from the United States. That's a BMI of 40. A typical patient in the US. I tell audiences if I have a day where more than 50% of my patients have a BMI of less than 40, I'm having a good day, all right? I had An experience 8 weeks ago at the University of Illinois. I was supervising 2 rooms, a registrar in each room. One room was surgery for morbid obesity patients. The other room was gynae surgery, vaginal hysterectomies, total abdominal hysterectomies. And what I'm telling you is the truth because it was so remarkable. I actually made the calculations. The BMIs of the ladies in the GYN room were more than the BMIs of the patients undergoing morbid obesity surgery. All right? Negative medical history, no allergies, normal airway. All right, let me tell you how I would do my case. Some of the things are identical to what you would do. Some are very different. And I'm going to get into specifics here. How I manage the Desflurane, how I manage my flows. And don't concentrate. I will make the PDF of this available to everyone. So you'll have all of these to look at later. Midazolam, I will typically give a woman like this 1 or 2 milligrams. Antiemetic, I typically give prophylactic antiemetics. I might give her 4 of dexamethasone at the beginning of the case, 4 milligrams, 4 of ondansetron at the end of the case. Why? I think the risk of postoperative nausea and vomiting is fairly high. If this is a female, and she is, and she's a non-smoker, based on those 2 factors alone, her baseline risk for PONV is 40%, and that's high. Glycopyrrolate, I don't typically do glycopyrrolate in my intubated patients. I do like glycopyrrolate a lot in my LMA patients. The reason why is it's my feeling a lot of the reason why people have problems with coughing with LMAs is because of secretions, and those secretions kind of working their way around the cuff to the vocal cords. So I think to the extent that you can dry those secretions up, I think that's a good thing. Fentanyl, typically that's probably the most common narcotic we'll use. I would either give 50 mics or 100 mics up front. The difference that I do, that I found between a lot of people here is I tend to give less narcotic up front with a goal of getting my patients breathing at the end of the case and then titrating more narcotic in rather than giving large fixed amounts, which is kind of a blind way. Propofol, 2 milligrams per kilo. Succinylcholine, people are saying, wow, succinylcholine, what's that all about? So let me explain. Do I give this to everyone? Absolutely not. But imagine the following situation. If I've got someone who's got a BMI of 40 or 45, and I've got a quick surgeon who's going to finish a case in 20 minutes, do I really think that I'm going to be able to give them an intubate with a non-depolarizer and get that endotracheal tube out at the end of the case? Extremely unrealistic. The US is not like Germany or Europe. We are like you. We do not have Sugamidex. Sugamidex is not FDA approved in the US. So if I've got someone who's morbidly obese for a quick case, I will intubate with Sux, follow with a small amount of a non-depolarizer. We do, and I know I've been here for a week. I know in all operating room theaters, theoretically, twitch monitors, neuromuscular blockade monitors are available. I also know that virtually no one uses them. They intubate with a fixed dose of a non-depolarizer, typically tracheum, and then redose on a schedule. If you do that and you're not monitoring, you run the risk of having too much muscle relaxant on board at the end of the case. And if you're using a volatile agent like Desflurane, where they're waking up quickly, you're going to really unmask that. If you're using isoflurane, where they're waking up slower, you may not see it as much. I mechanically ventilate the patient, non-depolarizer at this point. So if I've intubated with Sux, I'll give typically 2 mLs. I typically use rocuronium, vecuronium. I know tracheum is more common here. If this was a non-obese patient, a longer case, I would just intubate with a non-depolarizer. What I would do at 45 minutes, when my twitches started coming back, I would then give more neuromuscular blocker, typically 1 ml at a time, so that I would be able to extubate efficiently at the end. All right. What do? I initially go up to 6%. 6% is my magic number. The reason why I like 6% is above 6%, you have potential side effects of Desflurane. Side effects being tachycardia, hypertension, airway irritability. Below 6%, absolutely no difference between Desflurane or SIVO with regard to airway irritability or tachycardia. So I like to stay at 6%, then I know even with high flows, I will never get above 6%. I initially go with high flows. High flows for me, I'm calling 6 liters a minute. 6 liters of what? Okay? Before I intubate, it's typically 6 liters of oxygen. After that, it's whatever you're using. It's either 6 liters of combined O2 nitrous or O2 air. Most people in the US do not use nitrous, more than 50% at this point. I am unusual. I still will fairly frequently use nitrous, and we can address that later. I can give you, we heard the cons, I can give you some of the pros. 6 liters, I do that for 6 minutes. So the reason why I say 6 minutes, a couple reasons. It's easy to remember. 6, 6, 6, 6%, 6 liter flow, 6 minutes. If you do the time constant stuff, you're pretty close there too. That's almost 6 time constants. So you're very close to about 6. So people say 6 minutes, you know, what about 7 or 8 minutes? Doesn't matter. The point is not 1 minute. You need to do it long enough to get it up there, and not for 60 minutes. If you're doing high flows for 60 minutes, all you're really doing is making Baxter rich. You're using a lot of volatile agents, okay? The reason why I can get away and use literally Desflurane for every anesthetic that I'm using is because I use it in a very controlled, intelligent manner. It's a low flow, low concentration. My average cost for my anesthetic is significantly less than the average SIVO user. The average SIVO user in the US does about 2 liter flows, 2%. If I'm at 3% Desflurane at 0.8 or 0.6 liter per minute flows, my anesthetic is less expensive. Surgery starts, what do I do with the Desflurane? Absolutely nothing. I don't go down on my concentrations. Why would they? Why would I? They're about to start the surgery, the most stimulating part, so I wait. I do come down on my flows now, initially to 1 liter. So at the start of the surgery, I'm 6% Desflurane, 1 liter flows. I'll continue my non-depolarizer, but I will monitor for it. My goal is toward the end of the case, not give any more, get them breathing on their own. Now I start decreasing my Desflurane. I'll do that pretty quickly if I have nitrous on board. It's pretty easy to go from 6 to 3 pretty quickly. If I'm Aero2, I'll come down a little bit more slowly. So flows, I'll go even lower, under 1 liter a minute, 0.8, 0.6. I'll typically stop at about 0.6 liters per minute. So at maintenance, I'm at 3%, 0.6 liters per minute flow. Toward the end of the case, I don't give any more muscle relaxant. I kind of let it wear off. I start encouraging the patient and getting them to ventilate. If I haven't given too much, if I've managed my volatile intelligently, which I have, haven't given too much narcotic up front, and then let my muscle relaxant off, the patient will, toward the end of the case, invariably breathe. If I can do this with patients of BMIs of 40, trust me, you can do this in India where everyone probably is a lot closer to BMIs of 25, all right? So it'll be significantly easier. Here's my logic why I like to titrate my narcotic into the minute ventilation. If I've got the patient with a good minute ventilation and they have narcotic on board and Desflurane on board, then I can feel pretty confident that at the end of the case, when the Desflurane is gone, that their ventilation is going to be at least as good. So toward the end of the case, what I'm looking at here is minute ventilations of 5, 6, 7 liters per minute, and tidal CO2 looks good, their O2 sats are good, and their Desflurane concentration is fairly low. 1 minute to go, what do? I do give, even if they're breathing spontaneously, they look good, I give some reversal at the end of the case, okay? I'm a big advocate of that with giving neuromuscular blocker in intubated patients. I also have a lot of heavier patients. We're a very litigious society. I'm never worried about the judge accusing me of giving too much reversal at the end of the case, okay? So I'll turn off the Desflurane then, 3 to 0, high flows, 100% oxygen, That's what it looks like at the end of the case. Usually I'll extubate within a minute. Summary, keep in mind, Desflurane, not sevoflurane. Two different drugs, even though those blood gas partition coefficients look the same, there's almost a 50% difference. And keep in mind, I know people love Desflurane for obese patients. That's obvious. I use Desflurane literally for all of my patients. This is a summary of the technique. It'll be in the PDF. That's it. Thank you very much.
Thank you, Dr. Hertz. And you have nicely presented about the advantages of Desflurane, why we should use Desflurane, and how to use. Now, any question or comment related to this topic? Yes.
Thank you. It's been a wonderful presentation by you. I am also pro Desflurane, and I used in something like 550 cases of brain tumors. Only concern was in these cases, before a concern, we had a very fantastic recovery. I mean, patients' attendants would like to communicate with the patient immediately on recovery, in the recovery ward. And that was very gratifying to us and the relatives. Now, the concern has been of increased brain volume due to Desflurane. All said and done, it also stimulates autonomic nervous system. So there is a rise in blood pressure, taking what you have already mentioned. So we tried sevoflurane from the beginning. Halfway, we switch it off and put the patient on Desflurane for the benefit of early recovery and what have you. Have you had such experience?
What I will typically do, because I'm asked this question very frequently, what I'll typically do in these cases is, again, I'm at 6% or less, so I'm not worried about the tachycardia. The 6% or less, there's no difference in tachycardia between the Desflurane and sevoflurane. Also, again, I'm not running very high concentrations. Often I'm working my way from 6 to 3, okay? These patients are paralyzed, and I'm hyperventilating the patients. So the combination of the lower concentration of Desflurane with the hyperventilation gives me the best of all worlds. I don't see the increase in brain volume. I see them waking up very, very quickly as you do, and I don't have that problem with the tachycardia.
Yeah, thank you very much.
Okay.
Not audible. Please come to the another mic.
William Shakespeare rightly said, to be or not to be is a question or dilemma. I don't have a question, I am having dilemma after listening to your wonderful lecture. I am working in rural hospital, Gandhiji's place, and rural population and poverty always go hand in hand as far as India is concerned. We generally use cost-effective drugs. Safety is important in anesthesia. We are not using or we are not doing bariatric surgery, but we are doing daycare surgery. At present, we are using sevoflurane with all other drugs which we have mentioned. Is it necessary? And we are finding that these sevoflurane, isoflurane, they are cost-effective drugs. So is it necessary to use Desflurane in each and every case? Because it will add economic burden on already poor people.
Okay, so you're worried about the relative expense of Des compared to sevoflurane. Okay. Question that I'm going to ask you, and you don't have to answer, but it's a question I'm going to address to the audience, and I want you each to mentally ask yourself the question. For those of you who say that Desflurane is more expensive than sevoflurane, do you know how much Desflurane actually costs and how much sevoflurane actually costs? My experience is most people don't even know. But let me tell you, the cost per ml in India is pretty much the same, okay? So, but it's not the cost per ml that determines the cost of what you're using. It's primarily the concentration you're running the anesthetic at and the flows, okay? I tell people very typically in the US when I speak to them, I tell the typical sevoflurane user who uses sevoflurane typically at about 2%, 2-liter flows, I find that very common. If those are the flows that you're running your anesthetic, and I'm running my anesthetic, or you're sick for the day and I'm doing all of your anesthetics instead, and I'm doing that with my 3% Desflurane at 0.6-liter flows, my cost of my anesthetic will be significantly cheaper than your cost, less expensive. So, in the US, we have 3 agents, Desflurane, isoflurane, and sevoflurane. I can say virtually no one. And there, isoflurane is like here, significantly cheaper than Des and Sevo. No one uses isoflurane. It's either Desflurane or sevoflurane. But if you manage your flows effectively, low flow, low concentration, you will be more cost effective actually with Desflurane.
I think machine is important, drug is important, but man behind the machine and drug is more important. If you know the skill and if you are skilled enough, I don't think that drug and machine plays much importance as far as the, not subspecialty, super specialty, but day-to-day surgery, it does not play much role. I may be wrong.
Thank you.
Thank you.
No more question, please. You may ask after this session, and we are moving on to next speaker.
Yeah, we have the last lecture.